Yep, brilliant. All right. Hello, everybody. I am Fiona. I am your host, I guess, and this is the wonderful Nadia Bhal, who is a consultant gynaecologist in Wales.
Yeah.
And for those who don't know who I am and the reason why I'm doing this, I run a thing called Harley Street Emporium. I'm a journalist. I've got about 20 years in health writing, and before that, I used to work for the Australian Broadcasting Corporation, and I've written for the Lancet and Australian magazines that go to doctors and things like that. So that is why we're doing this because Nadia is brilliant and I run this thing that is concentrating quite heavily on menopause and women's health. So there you go. Shall we start, Nadia? And I guess the obvious place to start, I guess, is really what is normal when it comes to bladder function, so we know what isn't normal.
Right. Oh, okay. Well, you caught me off there. So I'll just give you a little bit of a background about me and why I started with this. So the first patient I saw as a registrar. So I've been working in the NHS now for nearly 24 years. And the very first patient I saw, the first day I started with obstetrics and gynecology, was a 78-year-old woman who'd had close to 10 procedures to try and maintain continence. She had gone through, I mean, it was like a walking textbook, and it just really kind of gained my interest. And she'd reached a point where people were saying that this was it, there was nothing more that can be done. And she was a lovely lady. She was 78. She smoked about 20 to 30 cigarettes a day, but she had a very active sex life, very fit, lots of grandchildren, lots of children. And that just really struck me. So that was in 99. Fast forward now to 20 years later. And that's all I've done throughout my whole career is look after and help women with incontinence, prolapse, anything related to discomfort, because I feel that it's a condition which is associated with a heavy stigma, especially coming from the Middle East. A lot of women in the Middle East don't actually talk about it, but you can smell the urine. Like a lot of my family members, and I'd say to my mum, I can smell urine. Tell them, to come and talk to me. So I just feel that it's a very, very common condition. So incontinence, I mean, we all know what continence is. Continence is where we're able to control our bladder. So the general bladder can take up to 400 mils. So if you're looking at a bladder capacity, let's start with that. So as we are children, we should be able to maintain continence by about the age of 1 year to 1.5 years. And that should contain throughout our life where we're able to maintain continence. If, however, um, some children will not maintain continence till about 5, 6, and even into their teenage years. This can predispose you to a condition which is known as overactive bladder and urgency and urge incontinence. So it's always useful if you do suffer with a degree of incontinence to just jot your memory back to when you were a child, because you may remember actually having problems with your bladder, or your mum telling you that you had issues with the bladder. So it's not normal to carry on bedwetting till after the age of 5, and if you did and it carried on through the teenage years, it predisposes you to a condition, urgency and urge incontinence. So the normal continence, or how our bladder should function, the bladder itself is just like a balloon. It fills up with water. It kind of fills up with water from our kidneys. It reaches a certain capacity. You then get a signal which goes up your spinal cord to your brain to say, hello, there's a little bit of urine in the bladder. Is it convenient, or are you busting? And that's called urge. And we're usually not in the right place. It's not the right time to go to the toilet. So you would.
That's right.
Could,
I'm just getting you ready.
hello? Can you hear
Hang
me?
on. So can I ask everybody if you're not on mute, can you mute yourself? Because every time there's a noise in the background, you override Nadia.
That's okay. So yeah, so if you, so your bladder will say, your brain will say, okay, is it convenient? Not convenient? Let's defer the urge. And you're then able to defer it. So that's what we call your warning sign. So it's very normal to have a warning signal. Not convenient, let's wait a little bit longer. And then you reach to a strong urge, and then where you are severe urge, and you have to go to a toilet and void and empty your bladder. Okay. So the time you start getting a little signal is about 200 mils. So the reason why I'm mentioning this, because later on when we talk about bladder diaries, which you can do yourself, you can get a very good idea about your own bladder function. So we start getting a signal about 200 mils, which is about, I don't know, about half the size of this cup, okay? As the bladder starts to fill, we reach about 400 mils, you start getting a stronger, and you're thinking, right, I need to find a toilet now, I need to start getting to a loo, and by about 500 to 600 mils, that's your normal void, okay? And you would empty your bladder, and hopefully you would empty to completion. So the normal thing is that you have a nice, good, strong flow. In female toilets, we can always hear the women who are in the toilets next to us. It should be nice, long flow, finish, maybe a little couple of dribbles, wipe, and that's it. Okay, so the normal is 200 mils, you get a bit of a warning. 400 mils, you start busting. 500, 600 mils, you need to empty your bladder. Okay,
And
and
how
the
often
time
a day
interval
would you
between,
expect that? So
yeah, so
what would be normal rotation?
the time interval between a emptying your bladder to becoming full again should be roughly about 4 to 6 hours. That's providing you're drinking a normal amount of fluid. So of course, because the bladder is very closely linked to how much we actually drink, it's always useful to look how much are you actually drinking. So the normal, the correct amount of fluids we actually need for our bodies depends on our body weight. And so working in kilograms, which is what most medical kind of what we do, is the formula is 24 mils per kilogram. So if you are an adult that weighs 100 kilograms, which is quite a big adult, most of us are around anywhere between 60 to 70. So if you're 100 kilograms, your bladder needs, in order for it to be healthy, 2.4 liters of fluid a day. Okay. Now, if you are 50 kilograms, which is half that amount, then obviously you're going to need about 1.2 liters. So that thing of people saying, you know, you can never get enough fluids. Well, actually you can, because if you start over drinking and you're drinking more than what your body actually requires, you are going to be voiding a lot more. And I mean, it's very common in Wales. Everybody loves tea. I mean, if the aliens dropped in your garden, they'd be asking if they want a cup of tea. So I met a lady once who was drinking 6 liters of tea a day. 6 liters, and she came to see me because of incontinence. And so all we did was we gave her a bladder diary, and I can send Fiona a copy of a bladder diary if you want to get one, or if you don't mind paying, you can pay $2.99 for the Squeezy app, which is an app which is NHS endorsed. You can download it on your phone, and that will give you a bladder diary which you can actually fill digitally on your phone, and then you can actually print it off. You can send it to your doctor. You can take it with you if you're going to go and see your GP, or you can even take it with you if you're going to see your consultant.
I think the link to the Squeezy app is actually in one of those articles that I sent out with the email, the one about the physio and the pelvic floor. I think there's a link in that to the Squeezy app.
Yeah, and also the Bladder and Bowel Foundation, they also recommend the Squeezy app. So it's really good. I mean, I downloaded it on my phone. I mean, I am getting to an age where I'm starting to get some bladder issues, which is probably kind of with the menopause, but the Squeezy app, you can see it here. I don't know if you can see it on my screen. Yeah. So you've got like a little flower here, and it gives you a bladder diary, how to fill in your bladder diary. It then actually starts you on an exercise plan, because again, the bladder is very closely linked to the pelvic floor. So you can start off with a nice exercise plan, a physiotherapy plan, how to do pelvic floor exercises, especially if you have a degree of stress incontinence. So you asked me, Fiona, about the norm. So the norm is, as I mentioned, to have a bladder which has a bladder capacity of about 500 mils. That's what we like to see. You're voiding every 4 to 6 hours, depending on how much you're drinking, which is why it's useful to know how much should I drink, you know. And then usually we tend to say waking up at night, which is known as nocturia, which again is a common condition that we start to develop as we start getting older. We tend to say 1 time at night for every decade. So after the age of 60, if you're getting up once at night between 60 and 70, that's probably okay. 2 times in your 70s, 3 times in your 80s, you know, hopefully if we're living longer, you know, maximum of about 4 times in your 90s. So it's not normal to be up 5 to 6 times at night. That's not normal. And the bladder diary will be really useful, because when you fill in a bladder diary, it needs to be filled in over 3 days, ideally in mils. You would have to buy a jug. You take your jug with you into the bathroom, you measure exactly what you're drinking, what you're peeing, and you put it into your diary, and you have to measure exactly what you're drinking. So I tend to say to the ladies I look after, okay, if this is your favorite mug, measure how much does this mug take, or your glass, and then stick to the same glass for the 3 days, and not doing it 3 days when you're probably going to be 3 kind of normal days. Yeah.
That makes
So
sense.
that's kind of everything with normality.
All right, so then
Yeah.
we move into
Any
the what's
questions
not.
about that? Okay. So what's not normal is obviously incontinence itself is not normal. So if we start off with what's the most commonest type of incontinence we have, the most commonest type amongst women is stress incontinence. It's got nothing to do with your mental state or your emotional state. It's purely stress, as in pressure or putting tension and stress on your pelvic floor. And that could be jumping, sneezing, coughing, sudden movement. You know, some women tell me, I just tripped off the stairs and all the steps and suddenly I leaked. And that's because there's a lack of weakness within the pelvic floor. So stress incontinence is the most commonest type of incontinence amongst women. It can range anywhere up to about 40% of women will have a degree of stress incontinence. Up to 75% of women will leak occasionally after the age of 40. So it's quite common to have occasional leaks now and again, but stress incontinence seems to be the most common. The one that comes after that is mixed. Now, I'll move on to the least common one on its own, which is urge and urge incontinence. So urgency is a term. Am I speaking too fast?
No, it's fine.
No, okay. No, nothing got really to do with the menopause. There was a question there. So urgency is a term where you have the urgent sensation to void that is difficult to defer. So you get that feeling that you have to void and it's very urgent. You've got a hard time. You may or may not leak. So urge incontinence is incontinence that's associated with the feeling or the symptom of urgency. So when you have a combination of stressing, sneezing, trampolining, horse riding with urgency or urge incontinence, that combination is called mixed incontinence. And it tends to come after stress incontinence. And it's really important when kind of thinking about, you know, if any of you in the audience do have any form of incontinence, it's worth thinking about what type of incontinence may or I may not have, because the treatment for each different one is very different. And usually what we tend to say is that we would focus on what is the most bothersome type of stress incontinence. We would focus on that. However, most urogynecologists would want to try and treat and get on top of the urgency and the urge incontinence first, before kind of going very proactively and thinking about treating the stress incontinence. Because any treatment that we recommend surgically for, so say for example, you're a 48-year-old, you're leaking everywhere, you've got a degree of urgency, you've got a degree of stress incontinence, you can't go trampolining, you can't go jumping. You see a urogynecologist or a specialist and they say, well, you've got stress incontinence, we'll put in a tape, or we'll do a fascial sling, or we'll put some bulking agents. The problem is that in 10% of women who have any form of kind of surgical treatment for stress incontinence, their urgency and their urge incontinence becomes worse. So it's always important that we treat the urge incontinence first. Okay.
Should we start there actually? Because yes, obviously prevention is the key here. Are there
Yeah.
risk factors that that we can eliminate that would help us prevent any of this in the first place, and then we'll sort of move through the grades of treatment for surgery?
So if we were to think about why, so before we can think about the prevention, if we think about the causes of why we actually develop this degree of incontinence, so I think of the big C's. So childbirth, first and foremost, is probably the most contributing factor to stress incontinence as we start to, after we've had our babies. Pregnancy itself is not, some women say, well, if I go ahead and have a cesarean section, I will avoid being incontinent. We know that having a cesarean section can protect the pelvic floor to a degree, and you're less likely to have stress incontinence, but you're not immune from it 100%, because pregnancy itself on its own, without childbirth, can also contribute to stress incontinence. It's just purely from the pressure of the pregnant gravid uterus itself and all the hormones that are going on. So pregnancy, childbirth is the top of the list as a cause. So we can't prevent not getting pregnant because life has to carry on. But we could, certainly if a young woman were to come and see me who's been totally dry pre-pregnancy and suddenly in the pregnancy develops stress incontinence, I would have a very low threshold to offer that woman a cesarean section. And the reason being is because I know that should she go for a vaginal delivery, the chances of her, she may have got a quality of life which was 10 before pregnancy, becomes 5 during pregnancy because she's now incontinent, has a baby vaginally, and suddenly her quality of life goes down to a 1 because she's totally wet post-delivery. So prevention there is probably having a cesarean may help to limit that risk. The second biggest cause of stress incontinence is obesity. And probably obesity is one of the only big modifiable factors that we can do to help reduce the severity of stress incontinence. So the bigger we get, the more pressure we put on the pelvic floor. And as we get bigger, unfortunately, we also store fat in our muscles. So we can't contract the pelvic floor as well because there's little fat globules which are between the muscle layers. So obesity is a large modifiable factor, and according to the NICE guidelines, women who have a BMI over 30 should really be encouraged to lose weight, reach a normal BMI before considering any form of especially aggressive management, especially surgery. So childbirth, pregnancy, obesity, and then as we go through the menopause, for example, hormonal changes that again has an impact on the pelvic floor, because lack of estrogen can weaken our muscles. As we go through the menopause, we start developing a degree as well of sarcopenia. We lose our testosterone. Our testosterone kind of doesn't help. We start losing our muscle mass. And so hormone changes will contribute to that. And then again, any form of surgery, if you've had kind of surgery within the pelvic floor, or any nerve damage to the muscles, those can contribute to incontinence. Now, with regards to urgency and urge incontinence, this is a completely different pathway. So with urgency, there are abnormal signals that are going from the bladder to the brain. So if you were to fill in your bladder diary, I've seen bladder diaries where some women have literally had 20 mils of urine in their bladder. I mean, that's nothing. That's like two dinner spoons.
Tablespoons.
Yeah, or a tablespoon of urine. Now, what happens there is the urine comes into the bladder, it sends an abnormal message up to the brain to say, oh, there's urine here, we need to go. So of course, you go to the toilet to try and void, you pass about 20 mils, but the bladder still isn't comfortable, so it starts contracting. So the muscles in the bladder wall start becoming bulky. So you get bulky muscles, which is what we call, kind of in a medical term, is trabeculations. So the muscle, so when I do a cystoscopy and you look inside the bladder, it's got all these crisscross tram lines, which are actually the bladder muscles are getting thickened, and because it's trying to squeeze this urine out. Any form of nerve damage, so especially if you've had like spinal surgery, or you've got a disc prolapse, or worse still, like a cauda equina, which is where you get a prolapse right down at the bottom of your spine, that can have a function on your bladder and your bowels. So fecal incontinence, bladder incontinence. If somebody's got a disorder like MS, so multiple sclerosis, any kind of disease within the spinal column, that can lead to a degree of what we call a neurogenic bladder. So anything that involves our nervous system, especially our spinal cords or the centers in our brain, if they're affected by MS, they can have an impact on the bladder, leading to this urge incontinence, a very muscular, trabeculated bladder that doesn't like to hold a lot of urine in it. Okay. And the other issue is psychological. So we get into the habit. So when we're children, our mothers will always say to us, right, quickly go to the bathroom, go to the toilet before we get in the car. So we all go to the toilet and we try to pass a bit of it. Did you empty your bladder? Did you have a wee? Yes, go in. So those are bad habits, actually. We should be going to the bathroom when we actually feel like we need to go, because we get into bad habits. Or I get into bad habits before I operate. I know if I'm operating and I'm going to be doing a 3-4 hour type of surgery, I like, hold on everyone, I'm just going to the bathroom, I'll be back now. I don't need
That's
to
not
go.
surprising if you're going to be operating. I mean, today you operated for 7 hours, for God's sake. You must have a bladder of steel. But I guess the question out of that is can you retrain these bad habits and
Absolutely.
extend that period of time?
Yeah. So coming on to, so those were all the causes. We've gone through the kind of what's the normality, what's the different types of incontinence, what are the main reasons why we become incontinent. So so if we know what causes incontinence, then we can think about how can we prevent it. So we spoke about very briefly about possibly having a cesarean with childbirth. If we're gaining weight, let's try and get on top of that. Anything that leads to increased pressure. So if you've got a really bad cough, try and get on top of your chest sooner rather than later. And constipation is a
I was just
big,
about to
big
say that.
thing, because when we become constipated, the bowels, they dilate. Now, the bowels sit right in the middle of the pelvic floor. So the levator muscles come from each side and they hug the urethra, the vagina, the bowel. If you've got a big, massive lump of poo sitting in the middle of the pelvic floor, you can't contract it. So You can't actually, when you feel like you need to have a wee, you can't, or you're going to leak, you can't do the knack. The knack is contracting the pelvic floor at a time when you need it. So you're going to sneeze, you want to do the knack to hold everything in, but if you've got a weakness in the pelvic floor, or you've got something that's stopping it from contracting properly, then that is going to make things worse. So constipation is a massive, massive issue that I've noticed. I don't know whether it's our diet, but certainly in the UK, I've worked in the Middle East before, so there's a big, big difference. We don't drink enough water. I think that's a big one. If you genuinely put your hand on your heart and say how much water you drink, I'm not going to lie. I drink about 7 or 8 cups of coffee a day, maybe 2 cups of tea, and maybe 1 cup of water. We're not good water drinkers, but we do need water for our bowel. And obviously fruit, we need to increase our types and the good types of fruit that are good for our bowel habits. So apples and pears are not great because they lead to constipation because of the pectin within them. So you'd use things like papaya, melons, things that have got kind of good amount of fluid within them. Yeah, so that's kind of just a little bit about prevention.
What about smoking? That's another risk factor that people say as well for bladder issues, that, stop smoking.
Well, we tend to say, I mean, I don't think that the bladder itself, obviously, smokers will have a higher risk of bladder cancer. So the nicotine within cigarettes will increase the risk of developing bladder cancer. The reason why I would tell somebody not to smoke is because I've already looked in their bladder, there's no evidence of cancer there, is because smoking leads to COPD, leads to a bad chest, leads to coughing. So you'd want to stop the smoking to stop the coughing. That will lessen the impact on the pelvic floor.
Yeah. Some of the I just noticed when I was doing a bit of research today and wandering through various sites, because there seem to be an awful lot of devices, supplements, and God only knows what else on the market that say that they will help you with stress urinary or urge incontinence. And obviously they offer advice, as do the manufacturers of incontinence pads. And some of them were this really surprised me, because you're saying we should drink water, and some of them were saying withhold your fluids, only take tiny sips of water, and things like this. Is there any logic to drinking small amounts? So, because I would imagine that if you had quite bad incontinence, you would be very tempted to stop drinking. But could that be actually a very dangerous thing to do?
You should not stop drinking. So that formula I gave you of 24 mils per kilogram is the minimum healthy amount that you need for a healthy bladder system. You also need fluid for your brains. So if you are drinking too little, your urine actually becomes very concentrated, which in itself becomes an irritant to the bladder. So the best way to know if you're drinking enough is to look in the loo after you've had your first wee in the morning. And there is a kind of big campaign about the color of our urine. So if your urine is watercolor, then you're definitely drinking more than enough. If it's got a bit of a yellowish tinge, that's probably okay. But if it's becoming a little bit more towards orange or dark orange, then you're dehydrated. So your first void in the morning gives you a good idea about whether you're drinking enough or not.
Good to know. Very good to know. All right, so we've got through those sorts of things. When we come, okay, so we've got, let's say with stress urinary incontinence,
Mhm.
what are the best ways that we can manage this, especially for menopausal people? Can it be improved with HRT for a start? Is that going to make a
Yeah.
difference? It should be topical or systemic or both?
Yeah, well, I just had a little look at kind of what I thought that we'd talk about. One thing that I just do really want to mention is red flags. So any woman who's suffering with incontinence, stress or urge incontinence, there are a couple of red flags that would require an urgent referral to a specialist. And so anybody who sees blood in their urine, so kind of visible, what we call macroscopic hematuria, in the absence of having a urinary tract infection, especially over the age of 45, would require urgent referral. If you've got unilateral, one side or two sides loin pain, kind of at the back, this region here, kind of where your kidneys are, that's also something to bear in mind. Recurrent urinary tract infections, so 2 within the last 6 months or 3 within the last year that don't seem to be getting treated with antibiotics, is a red flag. And anybody who has pain when passing urine with a raised white cell count over the age of 60, these are urgent referrals to a rapid access clinic. Okay, so if any, I mean, it's not infrequent, and I'm really sad to say that I do see some women who have got severe urgency, which is kind of, sometimes urgency can be quite painful. So they've got bladder pain, urgency, recurrent urinary tract infections, and it's been going on for months and months and months. These women need rapid, or even men require rapid urgent referral. So those are just something little that I just wanted to mention about red flags. In terms of treatments, okay, so as most urogynecologists, GPs, we all kind of go according to the NICE guideline, and the first top of the list is any form of incontinence should be kind of treated with a conservative management first. So as we mentioned earlier, we'd look at the behavioral things. So weight loss, so looking at your diet, if you've kind of put on a large amount of weight and your BMI is over 30, then weight loss may help with the bladder. Behavioral things, so that habit, kind of, we'd look at bladder retraining. So does there seem to be a habit when you're getting home and you're putting your key in the door? Is that when your bladder starts to trigger? So we do send a lot of our patients to our continence team, where they will help them with bladder retraining. And bladder retraining is quite simple and anybody can do. If you do your diary and you think, oh, well, actually, I'm voiding only 100 mils every time, you've got a small bladder there. You need to start thinking about stretching your bladder. And it is well and truly, most of the time, mind over matter. As I said at the beginning, the bladder is just a balloon that fills and empties with water, fills and empties with water. The center that controls the bladder is actually here in the brain. Okay, so I've been working with a colleague recently about starting to develop meditations for bladders, because if you understand what is actually going on, bladder retraining is all about very gently starting to stretch your bladder. So you have that urge to go, you try and defer your voiding for a couple of minutes, and every time you start increasing that by 5 minutes, 10 minutes, 15 minutes, 20 minutes, and little by little your bladder will start to stretch. And I think in Birmingham Women's Hospital, they do actually, on the ward, they used to have 2 beds where they would actually admit women into those beds for formal bladder retraining over 3 days to kind of conquer the habit of going. Now,
I'm just trying to imagine that it was like, nope, you're not getting out of bed. We're not bringing your pan. You are just staying there. I've got the clock on. I'm actually doing this at the moment because I realized that I was going to the toilet probably every hour and a half, and I thought this is just ridiculous. I've now managed to stretch it out to 3 hours between. Can I just take you back 1 minute, because there are a couple of important questions here, and the first one, well, actually the second one is from Maria, and she's asking about if there's a little bit of light pink color after she wipes. It's been a week and only tiny bit. Should she worry? Could that actually just be something that's from a bit of torn tissue, a hemorrhoid, a fissure? Could it be anything else? Should she be worried?
pink loss from the bladder for the last week. First and foremost, I'd get your urine tested. Make sure that you haven't got a little bit of a UTI, because a UTI is a commonest cause for kind of pinkish tinge or hematuria? Are you leaving it too long before you empty your bladder? So all of us will remember being pregnant and waiting for our ultrasound scans. Your bladder is absolutely busting to go. And when they dipstick your wee at the end, there's a little bit of blood in it. That's not uncommon because you have actually stretched your bladder more than what you should. So I would also be mindful of the age. So if this lady is postmenopausal and has a pinkish loss, we need to make sure, is it coming from the vagina, you know, which is tinging the urine to make it a bit pink. So I would be kind of a bit mindful and wear a little pad, because if that pad, in the absence of wiping, is a bit pink or red, then that requires an urgent referral to be seen, to have a scan and make sure that the uterus is normal, or that there could be a bit of vaginal atrophy. So the other thing that can cause a little bit of pink coloring is if there's a little bit of a urethral caruncle. So where the which is a sign of the menopause, lack of estrogen, the little tube from the bladder which is exposed to the outside, the mucosa starts to prolapse outwards and it looks like a little cherry there. That's lack of estrogen, and so sometimes some estrogen therapy. But I think first and foremost is, if you do have a bit of pinkish loss, a bit of discomfort that I can see there, a light pressure, and you're postmenopausal, definitely see the GP, at least have a urine dipstick. And if there's no blood there and you've continued to have a pink loss, then I'd recommend an ultrasound scan to make sure that the womb is normal.
All right, and let me ask the other question too. It's very similar to Victoria's question there. And it was a lady sent one in before asking, could we ask this? And similar age group, in 60s, on HRT, says just the bladder has sort of started now to not completely empty. Should she be worried, or is that just a sort of natural part of being menopausal?
Well, first of all, I'd ask, what do you mean that the bladder's not complete emptying? Is that because you don't feel that your bladder's emptied completely? So you've always got a little bit of a pressure there within the suprapubic area? Or is it when you stand up and you start dribbling? Because standing up and starting to dribble and having to sit down again, which is what we call double voiding, is a sign of an overactive bladder. Okay, if you've emptied your bladder and you feel, oh, I don't think I've emptied it completely, that could be sign of a prolapse. So a cystocele, a weakness in the anterior wall of the vagina where you're not emptying your bladder completely, and that would just sometimes require having a pessary for the treatment of prolapse, and that helps to help you complete your bladder emptying.
Which of course is tomorrow's topic. And yes, and going back to poor Victoria up here, who's been waiting for a long time, should she be worried then at the age of sort of in the early 50s, where in the age of 60, at the beginning of nocturia, based on normal menopause, age of 51, or other factors? So basically, yes, I suppose you mentioned it before, didn't you, with the once or twice up a night per decade would be considered relatively
Yeah.
normal.
So what I mean, as we get older, sadly, the um, bladder control centers in our brains start to decline, and our bladders start becoming smaller. Everything just goes downhill, isn't it? Sometimes as we get older. So waking, I think if it comes on suddenly, that's slightly different. So if somebody is perfectly well, fine, in their 70s or even 80s, and then all of a sudden their bladder function is changing and they're getting up quite a lot at night, then the bladder diary is really useful, because what we'd be looking for, nocturia is going to sleep, your bladder wakes you up, and then it's preceded and postceded by sleep. That's nocturia. Nocturnal polyuria is slightly different, and that can also happen where so we see this quite commonly in the elderly, where you're sedentary most of the day. You go to the loo, come back, sit down, watch TV, and then go to bed at night, and you're up and forth all night, back and forth to the loo. A bladder diary would help us see how much are you passing at night? Because if you're passing more than 1/3 of your urine volume at night, that's abnormal. And that could be a sign of an underlying heart condition, kidney condition, or just poor bladder clear out. So kind of just nocturnal polyuria. So a bladder diary is really useful to see that. And when would we count the amount of urine at night? So you have to have fallen to sleep first. You then get up at night. I know it's a bit of a pain, but you measure your wee, and then that nocturnal polyuria would include the first void of the morning as well. So if you're back and forth all night, and then you've kind of been weighing 100 here, 100 here, 100 here, and that's about 300, 400, and then you have a void of about 300 in the morning, your first void, that total amount is part of your nighttime void. And if that is more than 1/3 of your daily voiding, then it would require further investigation.
That must be so annoying for people to have to get up that many times in the night. That would drive me nuts. Mary is asking here, does the amount of daily liquid intake include tea and coffee? Because this is, yes, one of the things that you're avoiding tea and coffee, avoiding too much alcohol, all of those sorts of things. I'm like you, I live on tea. I probably have 6 cups a day and 1 cup of water. So, yes,
Okay,
does
so
it have to be
first,
non-caffeinated?
so my mantra is that we should be happy living. Okay, there's no point in us not drinking or not doing the things that we totally enjoy and going to the grave. Okay, I love coffee, and although I tell people not to drink coffee, if you can't do without it, because it's my favorite drink of the day, I wake up by, Fiona knows, I wake up by 4:45 every morning. I do my yoga, I do my meditation. 6 o'clock, I'm having a jug of coffee. 7 o'clock, another jug of coffee. But I do stop my coffee intake by 1 o'clock in the afternoon. And so I would have the rest of my drinks after 1 p.m. So if you like your caffeinated drinks, don't go without. You have to live and be happy. So drink your caffeinated in the morning, set yourself a time limit, and then go for decaffeinated after that. And yes, I think, Mary, your tea and coffee fluid intake does count within your daily budget of fluid intake. But the reality is that there is nothing better for our bladders than water. It's the best thing to drink. And if you're not a big water drinker, just maybe drink it a bit warm rather than cold. Add a slice of lemon, add a slice of ginger, jazz your water up to make it, yeah, that's it. Jazz your water up to make it more appealing. And actually, for most people who start drinking water, if you just do it kind of a habit, okay, for the next week, I'm going to drink it's really good for your bladder, for your kidneys actually, is to have a slice of lemon in the morning with a warm water. It flushes out your kidneys. And our elderly grandparents, they would always kind of drink a glass of warm water in the evening with a bit of lemon. So it's really good for your kidneys. So try and do that just for a week and see whether that kind of can increase your water intake.
I was just saying, I love water. Probably been drinking too much of it every day. See, I'm not a great water lover. I do train myself. I have managed to probably drink 3 or 4 glasses now, but I find it really dull. But there you go. There you go. Each to their own. So now, where were we? We were up to
Okay,
the conservative management. So we've all right. So
right.
we've looked after our weight. We've looked after our constipation. We've looked after those sorts of things. Are there? I guess is the next level up from that.
So
Actually,
conservative
medication.
manage. So moving up from there, if we were looking at stress incontinence, then physiotherapy. Uh, if you can't get to see your physiotherapist in your hospital, I think it's a good investment to see a good physiotherapist to give you a good assessment of the pelvic floor, see what's happening, because even though we think we know that we're doing the pelvic floor exercises properly, it's not until a physiotherapist actually examines you and tells you which group of muscles need to be contracted. And indeed, not all women will actually benefit from pelvic floor exercises. Some women have got what we call a hypertonic pelvic floor, so it's actually really contracted. but they've still got stress incontinence. And what those women need to learn is how to relax the pelvic floor and then tighten the correct group of muscles. So pelvic floor exercises, as I said, the weight loss, and then we've got some of the vaginal aids that help with stress incontinence. So NICE guideline doesn't recommend using vaginal aids as straight off. But if you are struggling and you don't really want to think about surgery, because at the end of the day, the ultimate treatment for stress incontinence is actually surgery. Okay, but you could consider something like this. So this is a continence ring there.
I love these.
Yeah. So we call this a ring with a knob. I just call it a continence ring.
I call it a door handle.
So this little part here, the knobby part, would, so you'd put it into the vagina. So if, actually, where's my vagina? Yeah. not my vagina personally, but this vagina. Sorry about that. But so this would kind of pop into the vagina that way.
It is huge, I have to say. That is an enormous thing.
What? This?
Yeah.
This is not really big. And so here, I don't know if you can see, you would, yeah, so you'd see the ring would sit behind the cervix. So a lot of women who are self-managing with their ring pessaries or continence ring, the ring has to sit behind the cervix. So this is the uterus here, this red thing here. And come down, here's the cervix. So you can see the ring is sitting behind the cervix. Now, if the ring, let me just kind of take this out here. If the ring kind of sits and goes above the cervix, it'll be painful. Or indeed, if it hits the cervix, it won't sit comfortable. You're trying to kind of move your pelvic floor around. So, but what I'm trying to say is that the knob needs to be sitting underneath the urethra. And then when you cough or you sneeze or you jump suddenly, the little knobby bit will go up and close the urethra. Okay.
Oh, clever.
There's also this one, which is Eurista. This has come out. These are little cones. There's different sizes. You've got a medium, small, and large. And you put this in, and it's like a plug. You put this into the vagina, and it kind of sits in the vagina like that. Yeah, you can just see there. So yeah, it sits inside the vagina, and that helps to close the urethra when you cough, jump, or sneeze. And there's other ones like IncoStress as well.
I'm guessing you have to take these out when you have sex. You're not leaving them in there all the time.
Well, actually, the ring pessary, these ones, some of my patients, they have sex with this in. Okay, because what happens is it doesn't sit like that in the vagina. It actually sits like that. So when the penis comes in, it kind of goes like that. So it kind of it doesn't always hit the ring. Okay.
I was about to say get smacked on the head, but I won't.
Yeah, it's a bit like the where's my other books stuff I got here? It's a bit like the E-string pessary as well. So, I mean, the E-string is lovely. You can definitely have sex with this in, okay? In fact, a lot of women say sex feels better with this in because it makes the caliber of the vagina a little bit smaller. So things feel a little bit tighter. So you can have sex with those in. So you've kind of had vaginal devices. You've got the IncoStress as well, which you can buy. This sits in the vagina, especially at night, and it's like a cone, so it kind of as well helps to tone up the pelvic floor. Now, if these don't work, conservative management doesn't work, you've done your pelvic floor exercises and you've done your conservative management, the next step up would to do urodynamics, which is a formal diagnosis of the of your condition. NICE says you don't have to have urodynamics if you've only got stress incontinence, but in practice, we hardly ever see women who only have stress incontinence. And as I mentioned before, if we go ahead and do surgical treatment and we've missed an underlying urgency in urge incontinence, that could potentially make it a lot worse. So we've had urodynamics and we've decided that we're going to go for surgery. Then what most people would recommend now is kind of first line is bulking agents, something called Bulkamed. And this can be done with you being awake or put to sleep. And we would inject an agent we'd come in cystoscopically into the urethra and inject an agent to bulk up the urethra. So when you cough or sneeze, it closes down. And then after that, we would be moving on to more kind of more major surgery, like fascial slings. We no longer do TVTs. Very, very few urogynecologists now put mesh in. So we'd use your own tissue. For example, we'd harvest some tissue from your tummy, from the wall of your tummy, and put that sling in. Okay. Looking at the conservative management for stress, for urge incontinence, as I mentioned, bladder retraining is crucial. Behavioural therapy, breathing. You know, I personally started to develop OAB last year, and I noticed every 10 minutes I felt like I needed to go. I just started to breathe. I'd sit down and I would breathe through the bladder contractions, and little by little, I'm really pleased to say that my bladder capacity has definitely improved. So I think, being a woman myself, going through the menopause, I'm trialing and testing everything on myself. So I've got an E-string pessary in, which is fab. You know, and estrogen. So estrogen therapy will really help with the bladder. Especially if it's urge incontinence, re-estrogenizing the tissues really helps. So whether that's with creams or with an E-string pessary. Interestingly, oral HRT, so oral estrogen, increases your risk of stress incontinence. So it's not uncommon that I'll see women who've started on oral HRT and develop stress incontinence. And I don't really know exactly what the link is, but it's not uncommon to see that.
Wow, that's really interesting. I've never heard that before. Is that because most of the oral HRT are synthetic, whereas the transdermal and would be body identical? Do you think there's any difference? Are they?
I'm
What is?
not too sure. I haven't really gone into why, but I do know that women on systemic HRT orally will it'll worsen their stress incontinence. So it's something to bear in mind. There's a lot of medication as well. So doxazocin, an antihypertensive, can lead to worsening of stress incontinence. So I tend to write to the GPs if they're on that. And then I don't know if any of you've heard of duloxetine. Duloxetine is also an antidepressant, which is called Cymbalta. Now, it's the same drug. Cymbalta is an antidepressant, but for some women, we will use duloxetine, especially if they cannot have surgery. They're at their wits' end. They've tried everything and they've still got stress incontinence. We'll consider duloxetine, which is medical treatment for the stress incontinence. Now, with regards to the urgency and the urge incontinence, as I mentioned, topical estrogen is good. You can use creams, pessaries, rings. And if all of that with the bladder retraining doesn't work, then you could consider tibial nerve stimulation, which is like acupuncture. You put a needle behind the ankle and we stimulate the nerves that go towards the bladder, which relax the bladder. That should be available now in most NHS hospitals. It's NICE recommended. A lineup from that would be Botox. So if you remember, going back to the beginning, I mentioned those thickened muscles inside the bladder. So if all treatments have failed, then we'd consider putting Botox into those muscles cystoscopically, and that paralyzes the muscle and allows then the bladder to stretch, especially women or men who've got what we call a neurogenic bladder. So they've got multiple sclerosis, or they've had spinal cord injuries, then their bladders are tiny and shrunk. And so what we need to try and help to allow the bladder to stretch a little bit. So we'll put Botox into the bladder. There is also SNS. So anybody who also has a degree of fecal incontinence, SNS will help for both the bladder and the fecal incontinence, as
What
well
does
as
SNS stand for?
sacral nerve stimulation. So we've got the posterior tibial nerve stimulation, which is like the acupuncture needle, and sacral nerve stimulation is where we put little electrodes into the spine and we kind of stimulate the bladder from above, whereas posterior tibial nerve is kind of stimulating the bladder from below. And then failing that, you've got obviously more major surgeries, which are very uncommon.
Let me take you back for a second because Maria is just asking here, are there any alternatives to vaginal creams that could be used? I know there's a lot of vaginal moisturizers and things on the market at the moment, but I guess that the whole point of the estrogen is that it re
Estrogenizes the
strengthens,
tissue.
yeah, sort of it
Yes.
gives strength to the wall, whereas the moisturizer
Yeah.
would be better for lubrication. But is there anything else that could be used if you couldn't use a vaginal estrogen cream?
Well, I don't think there's much women now who cannot use vaginal estrogen. Even women who've had breast cancer, now we tend to use estrogen because we know that estrogen alone doesn't really increase the risk of breast cancer. So if you're looking at anything specifically for the bladder, there are treatments that, I mean, sometimes recurrent urinary tract infections with painful bladder can overlap with overactive bladder symptoms. So sometimes Botox helps for these. There used to be bladder installation therapy where we put treatment into the bladder once a week for 6 weeks and then maintenance doses. Now that's available by tablet form called Elmiron, and that helps to kind of give you a completely brand new layer of the bladder, inner layer of the bladder. So in terms of what can we put in the vagina to help with the bladder, really what we can do is really just the estrogen cream. That tends to help.
All right.
And
Um,
and the more novel treatments that are out there now, so things like laser therapy. There's going to be soon a new NICE guideline that's going to come out about using laser for stress incontinence and bladder kind of vaginal atrophy, and I work with radio frequency. And that has shown good results as well for overactive bladder, as well as for mild degree of stress incontinence. And just I want to mention before we finish, in case anybody does suffer with incontinence, these are really lovely underwear that I found, which look quite nice actually. And for women who have a mild degree of leakage, these are called Wherever, because it's quite expensive to buy all these pads all the time, but they've got a thin layer of carbon in the middle, and you can wash them up to 200 times, which I thought was really useful for people to know. They're called Wherever, and they're for men and for women. So
and when we say wherever, it's WEAR as opposed to a
yes,
place.
yeah. So
Okay.
Wherever
So
underwear, and
environmentally more friendly too, yeah.
absolutely. And the other thing is that if you are a bladder sufferer with incontinence, please go and get your radar key because you're entitled to it. So you can just, I think Coloplast as well, they offer these keys for free. So just www.coloplastcharter.co.uk, and it gives you access to any disabled toilet.
Oh,
Yeah.
that's useful for when people are allowed back out again.
Yeah.
Yeah. The are there other medications, just quickly before we sort of do wrap up? We will run over time here, but
Yeah.
that's not the end of the earth. Are there medications that can contribute to these problems, and others that people should be aware of as well? If they're on other medications, could they be making things worse?
Yeah. So alcohol, top of the list. So, and you know, alcohol does impact on our bladder function, especially if it's beer. That kind of is a big one. Um, Antidepressants, sedatives, some of these actually lead to not being able to pass water easily. So it's always worth looking at what are you taking. Now, in my practice, what I've seen in my patients, and I think that there is a link, and I think I'm going to have to research this, is anti antacids. People who take antacids like omeprazole, ranitidine, Gaviscon have massive problems with their bladder. They also have massive problems with their bowel. And I've been talking to a top nutritionist recently, and what they are finding is that our happy hormones are made in our gut. Now, our guts are meant to be acidic. And if we're taking antacids all the time, we are actually allowing bad pathogens to grow, bad microbiomes, which are inhabiting our gut. And as you probably all know, our gut bugs very easily go into the vagina, which is why we always say to wipe from front to back. Yeah. So always wipe from front to back, because when you wipe from back to front, you're actually bringing those bugs towards the vagina. And even having a little douche, like a little bottle of water, putting to allow to clean the vulva is useful. So talking to Sean, who's the owner of a company called the Chuckling Goat. If you want to Google it, it's an amazing product. It's kefir, it's natural kefir. They are doing a lot of research looking at how antacids are grossly affecting our gut microbiome. And because we're not having happy bugs growing in our gut, it's leading to depression, mental health issues, because our happy hormones are developed in our gut. And so if we are inhibiting that with an omeprazole, it leads to depression. It's also leading to gut cancer. So bowel cancer now is believed to be linked to our gut microbiome. And I am honestly of the opinion, and I don't think this has been researched, and I really want to do it myself, is that I find a lot of women on omeprazole have an overactive bladder. And I probably think it's because of the same reason, is that it's being on antacids is affecting the health of the bladder.
That's interesting, actually. So I guess, you know, adding in, if you're reliant on those types of drugs for a long period of time, then
Yeah.
perhaps add a probiotic like Simprove or something like that into your diet to keep on, and make sure that you get enough of those prebiotics
Well,
as well in your diet.
well, they produce the Chuckling Goat, which is goat kefir, and it's a probiotic, but they also supply you with a prebiotic. So you want to kind of redo your gut. And if anybody's interested in this, because this is something I'm really interested in, they also do these kits. They've just sent it to me. It's called Listen to Your Gut. And it's a microbiome testing kit. They send it to you, you send them a sample of your poo, then they send you a report and they will tell you exactly what's going on in your gut microbiome. And then you will have a follow-up call with one of their nutritional advisors to help you learn. And I mean, the stuff that they're coming out with is phenomenal.
Interesting. Yeah, it's again that whole sort of gut brain
Okay.
axis is it is, yes, it is vastly, it's a
Right.
huge area, a great new area, and a brilliant
Massive.
area to be looking at.
One thing we haven't spoken about, which I did really want to cover, because I just think it's important for everybody to be aware, is that when you have an overactive bladder, the mainstay of treatment is medication. And the top medication that you're going to receive are called anticholinergics, which is oxybutynin, tolterodine, fesoterodine, solifenacine. So there's about 7 drugs. Now, anticholinergics, okay, you want to get your bladder control, you want to get your bladder health under control, but they do have an impact on our cognitive function. And if you are taking these anticholinergics for a very long period of time, They can affect your brain function. And there is a list here of drugs. This is called the anticholinergic cognitive burden list. Now, in this list, you can download it from the internet. It'll give you different drugs. There's loads and loads of drugs here. And because polypharmacy is actually a problem where there's too many medication. But if you go down this list, I mean, I go down this list and sometimes I see some really young women in my clinic, 28, who are on things like ranitidine, Imodium, Tegretol, if they've anti-epileptics. Obviously, some drugs you have to take, but cocodamol, warfarin, other things. When you add up all of these scores, they will contribute to a risk of mortality, especially in our elderly. So I would just say for yourself, if you're on a lot of medication, look at what you're actually taking and go and see your GP and have a medication review so that they can work out what your anticholinergic burden is like. And I would urge to try and kind of wean yourself off things that you may be able to do without. If you have an elderly mum or an elderly dad and you're looking after them, just also it's important that they have a medication review every year, because increasing their anticholinergic burden will lead to problems like dementia and Alzheimer's in the future. And you can swap one drug with another drug. So I just wanted to mention that as something that I think is quite important, that maybe not a lot of people know about. There was a lady in America actually who managed to sue a pharmaceutical company because they started her on treatments, different types of treatments, and she gambled her house away, her car away, she gambled all her savings away. And it turned out that the drug that she'd been put on actually caused, one of its side effects was compulsive gambling.
Wow, it sort of took that inhibitory response away from her.
Yes,
Yeah.
yeah. And so, it's important to research what we're taking, because I mean, I'm not in favor of medication. I don't prescribe anything if I can avoid it. I think there's a lot to be said for holistic therapies, alternative therapies, looking at our lifestyles, prevention. I mean, that is my top go-to before I think of something invasive such as drugs and surgery, even though I love operating.
True. So basically, then the take-home messages from this are really prevention is well, obviously better than cure. What we can do is to make sure we're not constipated, don't drink too many caffeinated drinks or alcohol, lose weight, do our pelvic floor exercises, which will be tackled on Friday with a physiotherapist who will tell us the right way to do it, and also if we're hypertonic, what we should be doing about it. What else are our takeaway messages? If we get to a point, the novel treatments are going to be an interesting one. That's Thursday as well. So we'll be going through those just to see what sort of evidence there is now to say whether they do or they don't work. Because it's I guess this is the problem with things being novel, really, isn't it? That until the evidence is there, there's everybody's going to go, oh, as I got, a comment on one of the Instagram posts the other day, oh, show me the data. But, until you start actually using these things, you can't really gather the data. So, yeah, it's one of those sort of chicken and egg type things, I suppose, isn't it? With a lot of those things, you can only really go on what people are seeing and making sure that you have a good assessment to see whether or not you're actually appropriate for them. What else is there that we should sum up on this? And does anybody have any last questions that they want to throw in? You can unmute yourselves now and have a chat. Remaining quiet. Anything else, Nadia? Then to sort of to summarise what you'd your take home message apart from keeping yourself healthy.
No, I think, I just hope everybody finds it useful.
I think so because it is, the life, the idea of spending the rest of your life in nappies, really, if it can be avoided, would be a good thing.
Oh, that's right. If you do use if you use pads, you can reclaim that back, the VAT. So there is a form that you can download, because incontinence is considered a medical condition. So you should be able to reclaim your VAT. And obviously you can get pads from the NHS and from your continence team, but they tend to be quite large. I think they think women are like elephants. They're massive. So a lot of the women like to buy their own because they're a lot more comfortable. I think those underwear, I even think I'm going to buy one myself just so I can see what it's like and I can show it as a sample for everybody to see, because you can rewash them, so you can reclaim your VAT. You just need to download a form. I think the GPs would have it to reclaim the VAT.
Yeah, that's actually because it would a very very costly thing in the long run to I mean, I don't know how much they cost, but I imagine that over the year you could be spending thousands.
Yeah.
Yeah, which would not be good. Brilliant. All right. Look, thank you so very much for that. If nobody's got any last questions, let's let poor Nadia go and have some dinner since she's been operating all day and only eaten two bananas and a bit of banana cake.
I'm